Okay, so this is a topic that's been kicking around for 16 years because cell of origin as a distinguishing factor in large cell lymphoma was first described in 2000. So this is the WHO classification for the lymphoid malignancies of the large cell lymphomas in 2016. Clearly the most common lymphoma worldwide is diffuse large B-cell lymphoma not otherwise specified. It now has 3 categories: germinal center, activated B-cell, and unclassified. And these are to be reported every time in a pathology report. And the cell of origin determination is supposed to be done by the best available means available for that pathologist. Though we'll talk a lot more about what that means. There are many other subtypes of diffuse large B-cell lymphoma, but diffuse large B-cell lymphoma not otherwise specified represents the vast majority. Now, cell of origin is one of the contributing factors to the heterogeneity that we see clinically in diffuse large B-cell lymphoma. Clinical heterogeneity is clearly indicated by the fact that not everyone is cured with standard therapy. Even with the addition of rituximab, which was a dramatic and very important change in the treatment landscape, there were many patients who still fail therapy. Part of the identification of what happened occurred when we started doing gene expression profiling, and cells naturally grouped, and you can see on the left-hand panel of the heat map, into 2 groups: those that were red on the top and green on the bottom, and those that were green on the top and red on the bottom. And they happen to correspond to the heat signatures of normal germinal center B cells and normal activated B cells. And that's where these names came from. And it turns out that this really had a impact on outcome. So patients treated in the modern era with rituximab and CHOP had differences in progression-free and overall survival, even when treated with rituximab and CHOP, whether they were germinal center or activated B-cell or non-germinal center. And we'll talk more about this. But more importantly, activated B-cell diffuse large B-cell lymphoma and germinal center diffuse large B-cell lymphoma are simply different diseases. They have different molecular pathways. The activated B-cell lymphomas are very dependent on the NF-kappa B pathway, and there is more active signaling through the B-cell receptor. The germinal center B-cell lymphomas tend to have more tonic regulation, and the PI3 kinase mTOR pathway is more critical. There's more genomic instability in this subset. So there are really differences in molecular features and then hence potential molecular targets for the treatment of these diseases. So cell of origin determination identifies tumors with distinct biology, may provide prognostic information, and may be predictive for treatment. But unfortunately, cell of origin isn't the whole story. Genes get mutated just in large cell lymphoma, just like every other cancer. Here is some data from Memorial looking at a whole variety of mutations that can occur. You get a typical distribution map of mutations, and you can see they're color-coded here. There are some mutations that we see only in germinal center B-cell lymphomas. There are other mutations that we see only in activated B-cell large cell lymphomas. But you can see the vast majority of mutations are actually seen in both subtypes of diffuse large B-cell lymphoma, further complicating our understanding of the biology of these tumors. Now, some of these things can be targeted. In some of these mutations predict for sensitivity to treatment. Others actually predict for resistance. For instance, and we'll get into this a little bit more, CARD11 predicts for resistance to ibrutinib, whereas CD79B mutations actually predict for sensitivity. So If cell of origin is important, how do we determine a cell of origin? Well, this is one of the most important and misunderstood things. Cell of origin was originally based on a population study. We just asked which one of these is more like the other, which one of these is not the same, and we found out that there were two different populations of cells that grouped together. But you couldn't take an individual tumor and say, oh, you're a germinal center, you're an activated B cell. So this is actually a statistical model that allows us to go from gene expression profiling data to assign an individual patient a cell of origin. And what you can see is that we actually, the right classifier, which is what all of the subsequent work is based on, identifies three groups: a germinal center B cell lymphoma, an activated B cell lymphoma, and then this group in between that statistically was couldn't really be assigned to one group or the other. It was originally called type 3. We apologize, it was really a bad term. It just should be called unclassifiable. So we can do gene expression profiling on fresh tissue. It's the gold standard, totally not a clinical tool. We can use immunohistochemistry. Well, that's great. Pathologists love it. It's widely available. However, reproducibility is a bit of a problem, and there are many different algorithms for determination of cell of origin, and there may be lack of correlation with the gold standard. So if gene expression profiling is the gold standard, how do we do gene expression profiling on real clinical specimens? Well, we need to be able to do it on formalin-fixed paraffin-embedded tissue, and that is what has emerged in the last few years, the ability to do gene expression profiling on formalin-fixed tissue. So this is the most common immunohistochemical algorithm. It's called the Hans algorithm. It's based on three antibodies: CD10, BCL6, IR4, MUM1. And if you're CD10 positive, and the order that you look at these antibodies actually is really important. Different algorithms look at the antibodies in a different order. Hans looks at CD10 first. If you're CD10 positive, you're done. It's germinal center. If you're CD10 negative but BCL6 negative, you're done. It's activated B cell. If you're CD10 negative, BCL6 negative, then it's all about MUM1. And if MUM1 is positive, it's activated B cell or non-germinal center. And if it's MUM1 negative, it's then germinal center B cell. So here is a typical germinal center: CD10 positive, BCL6 positive, MUM1 IR4 negative. And here is a typical non-germinal center tumor: CD10 negative, BCL6 can be positive, but very strong expression of IR4 MUM1. So if we look, here's the model that I just discussed. This is the Hans model. We start with CD10. CD10 is the driver. There's another model that's quite useful. It's called the Choi model. The problem with the Choi model is it's dependent on this GSET antibody, which is not readily and commercially available. And actually, it is now, but it wasn't at the time this model was developed, so it wasn't easy to do in a widespread way. There is another very easy model, again, based on very standard antibodies, done in a different order. This order is critically important for the accuracy of the assay, and it's BCL2 rather than BCL6, then CD10, and then IR4 MUM1. So let's look how these different models behave. So gene expression profiling has consistently shown differences between activated B cell and germinal center tumors, with the germinal center tumors having a superior progression-free and overall survival. And this meta-analysis clearly shows that cell of origin was important prognostically. If we look at the Hans and Choi algorithms, you can see that these forest plots are on either side of one. Sometimes activated B cells do better, sometimes germinal center tumors do better, and if you look at the meta-analysis, they cross one. And this is a real problem because the accuracy and reproducibility of Hans and Choi is quite questionable. If we look at the Muris immunohistochemical assay, it actually a little bit more reflects that of gene expression profiling. However, the data is not as widespread or as large a number of patients, and that's reflected by the relatively large 95% error bars. So we really need to do gene expression profiling, and we really need to do it in formalin fixed paraffin embedded tissue. And so the Lymph2CX was developed in Vancouver using a technology called nanostring, which allows us to take RNA extracted from paraffin embedded tissue and assay it. So the assay was developed. And you can see the gold standard is shown below, and there is one case by the Lymph2CX, by this nanostring assay, that was misclassified in the original cohort, the original validation cohort. But you can see that there's tremendous correlation between the Lymph2CX and the gold standard. This is a very reproducible assay between laboratories, and it's actually also reproducible between different sets of the reagents. So this is a robust assay, and it does work. And in fact, if you take in a completely new set of data, you can actually show that in a completely independent cohort of diffuse large B-cell lymphomas, this is externally validated. So here we have a robust assay, and so it allows us to then ask the question, using this robust assay, is cell of origin prognostic in large cell lymphoma today? So this is a large data set, 340 patients, 339 patients from Vancouver, and showing that the cell of origin was in fact predictive for both progression-free and overall survival. But interestingly, the same exact assay applied to the Recover 60 data from the German high-grade lymphoma study group, which is soon to be published and was actually provided to me by Michael Freundschuh as personal communication, was not. There was a slight trend in favor of GCB tumors, but these are not statistically significantly different. And using a different assay, the Remodel B study using the DAZZLE assay, again, gene expression profiling in formalin fixed paraffin embedded tissue didn't show any difference between ABC or GCB. So do we not care anymore? Well, we do still care because remember, the biology of these tumors is different. Can chemotherapy influence outcome by cell of origin? So if we look at dose-adjusted EPOCH, everyone knows this regimen. We did a large multi-center phase 2 trial to confirm the NCI results, which we did. But what we found is that for event-free, progression-free, and overall survival, the germinal center tumors did much better. However, this was a phase 2 study. This is a hypothesis-generating experiment, and we are going to finally present the results of 50303 at ASH. So unfortunately, you have to wait for ASH for the results, and whether these data are actually confirmed. What about sequential non-cross-resistant chemotherapy? We did a sequential therapy of R-CHOP followed by ICE. And the result of this study demonstrates excellent progression-free and overall survival. When we analyzed the outcome by cell of origin, there was a suggestion that the patients with the non-germinal center tumors were actually doing better than the germinal center tumors. Now, one of the limitations of this study is that cell of origin was determined by the Hans model, which I've already alluded to is somewhat difficult. But it raises a testable hypothesis that sequential therapy might overcome the adverse impact of the non-germinal center tumors. There's another study that compared RACBP to R-CHOP. This was a prospective randomized study. Remember, RACBP is actually a complex sequential chemotherapy program. Here is the analysis by cell of origin. What you can see is the outcomes are very good, but when you look at cell of origin, when you look at the CHOP group of patients versus ACBP in the germinal center tumors, not a whit of difference. However, if we look at RACBP versus CHOP in the activated B-cell tumors, there's an enormous difference in favor of RACBP. Again, evidence that you can overcome the adverse effect of the ABC tumors with chemotherapy. But this raises the question that RACBP can do this, but how does this confirm the hypothesis that I just put forward with R-CHOP-ICE? After all, they're different regimens. Or really, are they? Well, in fact, they're not. And we didn't realize this until this data was published. But R-CHOP-ICE and RACBP with consolidation are actually remarkably similar regimens. They're both sequential with consolidation with high-dose ifosfamide etoposide. And these regimens are really quite similar, and so they actually reinforce each other, demonstrating a similar result. So what about new agents? So lenalidomide has been shown in the relapse refractory setting to have some modest activity in large cell lymphoma. But interestingly, when you apply the Hans model and you look by cell of origin, the benefit of lenalidomide in diffuse large B-cell lymphoma seemed to accrue entirely to those patients with non-germinal center tumors. So this led to the hypothesis that if you added lenalidomide to standard chemotherapy, you might improve outcome. 2 such clinical studies were done, one in Italy and one in the United States. These are the Italian data. You can see outstanding progression-free and event-free survival with rituximab, lenalidomide, and CHOP. Greg Nowakowski at the Mayo Clinic looked at a very similar regimen, and what they did is they selected patients from the Mayo Clinic Iowa SPORE for concurrent historical controls and identified 87 matched historical controls compared to their 64 patients who got treated with rituximab, lenalidomide, and CHOP. And if you look at the non-germinal center tumors, rituximab, lenalidomide, and CHOP did much better than the historical controls treated with rituximab and CHOP alone. However, among the germinal center tumors, there was not a hint of any difference. This confirms the hypothesis that lenalidomide was really benefiting the activated B-cell tumors and allows us to ask the question prospectively in a randomized study. There are 2 such studies. One is the ECOG study, which actually is using an unselected population to yet again prove the benefit is in the activated B-cell tumors. And then the robust study is a international study where patients are being pre-selected by the nanostring assay for being activated B-cell, and if they're activated B-cell, they get rituximab, lenalidomide, and CHOP. Another drug that has activity in large cell lymphoma is ibrutinib, and the single agent activity of ibrutinib, again, is relatively modest in an unselected patient population. However, if you look at this waterfall plot, you can see that most of the winners are activated B-cell tumors, and when we sort of dove into this data set some more, we really started to get some interesting results, and some of them are shown here. Among the ABC tumors, about 40% of the patients responded. The response was enhanced by mutation of CD79B but did not require it. If there was a CARD11 mutation, there was simply no response. That makes total sense. CARD11 is a protein downstream of BTK, the target of ibrutinib. So if you're mutated downstream, why would you respond? The confusing one is mutations of MYD88. If you were mutant MYD88 and you did not have a CD79 mutation, you did not respond but if you had a CD79 mutation, you actually had a great response. So exactly how this all interplays is a little bit tricky, but it led to us asking the question, can we do this in upfront large cell lymphoma? There was a phase 1b study of rituximab CHOP plus ibrutinib. The results, this was really just to prove you can give it safely, and the answer is you can. Interestingly, the overall response rate was 100% with a complete response rate of 91%. The recently completed Goya study has a complete response rate of about 70%. So a high complete response rate. This has led to a prospective randomized study. The accrual is complete, but the analysis is still pending. And this was rituximab and CHOP plus placebo versus rituximab CHOP plus ibrutinib. We should be getting these results in the next 18 months or so. So cell of origin in large cell lymphoma identifies tumors with distinct biology. Determination of cell of origin by immunohistochemistry is inexact. Gene expression profiling of formalin-fixed paraffin-embedded tissue is clearly superior and is an emerging clinical assay. The prognostic significance of cell of origin is a bit controversial, though I actually do believe that there is a prognostic difference in unselected registry patients. I think the effects of clinical trials have to do with biased clinical trial accrual. But treatments do seem to influence by cell of origin. We need to understand and confirm the good outcomes of germinal center tumors with dose-adjusted EPOCH. That data is pending. Sequential chemotherapy with ifosfamide etoposide consolidations do very well in activated B-cell tumors, both in phase 2 and phase 3 studies. But importantly, small molecules seem to have differential effects, totally predictable based on the biology of the difference between activated B-cell and germinal center tumors. But the big wild card here is somatic mutations further complicate things and will have to be incorporated into our understanding in the selection of patients. So with that, I'll stop. Thank my colleagues at Memorial and the NCCN institutions who have participated for years in the development of the NCCN NHL guidelines, which will now divide into 3 guidelines. We're actually, so if you thought that the NHL guidelines were complicated enough, we're going from 1 to 3 different panels. So.